I'm here to talk about TAVR, of course, which is not about techniques. I'm not going to talk about techniques. I'm not going to try to prove that TAVR has a place, because that's been done. And my conflict of interest is that I don't do operations and I implant TAVRs. So I'm going to talk about who should or should not, interestingly, have TAVR in 2024, where it should be done, who should be doing it, and how it should be done. And as I think the last discussion was alluding to the fact of lifetime management of aortic stenosis, I think we need to move in that direction, because all these techniques that we have heard from surgical colleagues and TAVR, they're all complementary in terms of decision-making in the patient. So I'm going to start with a scenario that I'm not going to go in detail at this point, and then I'll talk about TAVR. So, of course, we're talking about an older group here, a 72-year-old female. She has had aortic valve replacement. It's a small valve which failed for very obvious reasons. As you can see, it was trifecta. There wasn't, despite being a small valve, she never had any evidence of patient-prosthetic mismatch. And now she has biprosthetic failure with severe AS, and her surgical risk is intermittent. So while that scenario is in your mind, I'm going to talk about where TAVR stands right now. So this is a summary of both American and European guidelines. And you'll see that this expected survival in conjunction with surgical risk is the way to assess who should have TAVR and who should have SAVR. It's no longer just about the surgical risk, for very obvious reasons. And that's because the randomized control data has shown that TAVR has role in all surgical groups. So then it becomes about the durability of valve or expected survival. So if I have to summarize this, in Europeans would say if you are age less than 75 and your surgical risk is low, then you should go ahead and have surgical aortic valve replacement. And then surgeons can decide, techniques, aortic enlargement or not. Americans would say that if you are less than 65 and your survival is expected over 20 years, then you should go and have SAVR. And again, the details of that will be up to the surgeon. And you can see they're dividing in terms of putting emphasis on expected survival versus expected survival and risk. But it's more complex in real life because not many patients would just have isolated AVR. You would not be making those decisions just because of the expected survival or what's the risk of the patient. So this slide summarizes what other factors would play part. For example, the valve morphology. Bicuspid aortic valve can be completely different ball game. The other emphasis is on access, how the TAVR can be performed. If it cannot be performed through transfemoral access, then you have to reconsider other factors. Concomitant valve disease. Very often these patients would have other valve disease. They would have coronary artery disease, and the debate of coronary artery disease, whether they should have bypass graft versus stenting, would come into play. And there are other factors such as endocarditis or previous surgery, limitations for surgery. On the right side, I've got an anatomical criteria, which is important to mention, although the TAVR has been evolving, and all these anatomical criteria which were excluded as a part of randomized controlled trial between TAVR and SAVR are actually common occurrences in day-to-day MDT. So all of this has to be taken into account. So how we do TAVR nowadays? Of course, there are no sutures, I'm sorry, involved in this. The sutures that we do put in, we don't have to tie them. They come with pre-placed knot. It's done under local anesthetic in almost all cases with some conscious sedation. It's full percutaneous approach. There is no longer role of cut downs in over 95% of the cases. And they don't need transesophageal echocardiography anymore. They can be done with the transthoracic echocardiogram. When we are implanting them, then we, just like it was mentioned earlier in the discussion, that we moved on from just implanting the valve to a stage where we are considering what would happen to these patients in future. For example, what is their age, what is their expected survival, do they have coronary artery disease, would they need access to the coronaries, how long we expect this valve will last, and would they be suitable for redo TAVI should it be needed. And then in terms of planning, CT plays a very important role, and I've highlighted in the image on the left side the things that we need to consider: vascular access. Do they have conduction abnormalities? Because TAVI is associated with much higher risk of requiring pacemaker than aortic valve replacement done surgically. There's a risk of coronary inclusion. It's very low, about 1% or less. And there's a risk of annular rupture. So all of these factors have to be taken into account at the time of planning for the procedure, which happens before the patient comes to the cath lab due to CT scan planning. Where should it be done and who should be doing it? So there are a number of cardiac surgeons around the world who perform this procedure in conjunction with cardiologists, and I think that in many countries is the way forward. There is a debate whether or not these procedures should be performed in isolation in small hospitals or should be part of a larger group of heart team where all the options that we mentioned about a particular age group are available, so a more joint up decision can be made about the lifetime management of these patients. But that remains controversial. In terms of devices, there are a number of devices available, and it's growing, and they have evolved. For example, I'll mention this particular new kid on block, you could call, is made up of a bioengineered tissue. So we are also moving in the direction of, as you learned, that man-made tissue can be used in this situation. By and large, we will divide them by how tall the frame is, because that has implications for you if these patients were to come back for surgery. If you implant a very tall frame and these patients then need surgery, that is pretty much guaranteed aortic valve root replacement, whereas if you put a short frame, they can be operated upon as if you don't need to do root replacement. The other factors are supraannular versus intraannular leaflets that determines hemodynamic performance. Whether or not that hemodynamic performance translates into durability of one particular device over other remains unknown. Then the method of deployment, self-expanding or balloon expandable, and porcine versus bovine pericardium. And again, all of these things we're learning from surgical colleagues about the benefit of one over the other. And I think Resilia tissue technology was mentioned, and modern balloon expandable valve available to use today now have the same leaflet technology that you will implant surgically. So leaflets are the same. Now, a big question had been in previous years about the durability of TAVI. It's not that TAVI was a low-risk procedure, the patient could go home the next day. That is no longer the bar. The bar is durability, how long these tissue would last. And the reason I mentioned, if there's one trial you must read, is this Notion trial, which was carried out in Nordic countries, a low-risk surgical patient, albeit older, mean age was 79. That's the only randomized trial with a long-term follow-up, which wasn't directly sponsored by industry, and shows very clearly there is good news. There is no big difference between TAVI and surgery, so these patients can have both treatment. But what is interesting is that the durability of THV, which was a question, is as good, if not better, than surgical bioprosthesis. There is some criticism of the surgical bioprosthesis used because there was some mitral flow in this, and as we heard, the performance of mitral flow wasn't as good as other surgical valves. And from TAVI operators, you could say that this data belongs exclusively to tall frame supraannular valve, or whether or not we can extrapolate to other valves remains unknown. And this is again the same trial, and it shows the severe bioprosthetic valve dysfunction. Now, why this is important, why I'm emphasizing about this, is that until this data, all the data we had previously, the endpoint for surgical bioprosthesis was freedom from reoperation. And you can use that surrogate, but this is just a surrogate. It gives you an idea, because many patients will be turned down for surgery for other reasons, not that the valve has failed or not. But this is core lab analysis, as good as it gets, echocardiographic data, or up to 10 years. The criticism is numbers are very small. As you can see, it's a small trial, it's not a large trial, but it's randomized. Now, if you put this in context, and all the trials, randomized trials that's been done so far, and you can look at this surgical aortic valve replacement and TAVI, you can see there is no signal to suggest that transcatheter heart valve fail quickly. And we know from trifecta data that if that was happening, it will surface very, very quickly, and it hasn't thus far. Okay, so that was for trileaflet valve, transfemoral access, no anatomical exclusion, no concomitant valve disease. What if you have a bicuspid aortic valve? What happens? So bicuspid aortic valves were excluded from the randomized controlled trial comparing TAVI and SAVR. So if you are a purist, the trial data does not apply to the bicuspid aortic valve. But if you look at the data altogether, a lot of these cases are performed. So if you look at the difference between tricuspid and bicuspid, there is a very clear signal, albeit still low risk. There's increased risk of stroke with bicuspid aortic valve if you have TAVI, which is understandable. They often have very heavy calcification. And there is a slightly higher risk of annular rupture with bicuspid anatomy. So these patients are at higher risk. And when you're making those decisions based on age and risk, you may need to take this into consideration. What about alternative access? What if it's not transfemoral TAVI? Should you let your TAVI access these patients? So now this is observational data, but adjusted for risk. There does not seem to be a large difference between transfemoral access or non-transfemoral access if you adjust for the risk markers, because often the non-transfemoral access is in patients who have higher risk. And when you divide the different risks, it's very clear that transaortic and transapical carry higher risk, whereas transaxillary or transcarotid have the lowest risk. Across the pond in America, there is good split between transcarotid and transaxillary, whereas on the European side, transaxillary remains the predominant access for non-femoral TAVI. What about patients who have had previous surgical bioprosthesis? Again, the decision has to be individualized. TAVI is very successful, a very low-risk procedure, but TAVI is not going to treat your patient prosthetic mismatch or the risk of the patient prosthetic mismatch. So if there is a baseline patient prosthetic mismatch, that cannot be treated by TAVI, even if you can do what we call bioprosthetic valve fracture, as demonstrated here. There are valves that you can fracture and put a bigger valve than the original bioprosthesis. So if you are going to ever listen to your cardiologist, please do not put Hancocks, because we can't modify, we can't make them bigger. And trifecta, you're very well aware, we're not going down that route. But most valves can be either modified or fractured. And then what you get in them has different performance. As you can see, loads of redundancies there, whereas this is better expansion. Right. So, what happens if you do TAVI after surgical aortic valve replacement? Is it as good as surgery? Is it better? So the data, again, is all observational data, but large numbers in this meta-analysis here. You can see that for short-term outcomes, 30-day mortality, major bleeding, severe patient prosthetic mismatch, there are differences. So if you have patient prosthetic mismatch, it still favors redo surgery rather than TAVI, although you can perform a low-risk procedure. What about TAVI and TAVI? So if you have done a TAVI before, do they all need to have surgery? If a patient has endocarditis, they don't have a choice. We would be asking you if their risk is not prohibitive. What we know from explant registry is that the surgical mortality is somewhere between 12 to 25% if you operate on someone who's got TAVI, but that's also tainted by the fact that TAVI so far has been performed in older individuals with higher risk. I think that technique will improve for surgeons of future. I think you would not have any choice but to get experience in explanting TAVIs, because this is going to happen numbers may be small, but it's going to happen in future. So what we know about if you were to do TAVI in TAVI is the risk remains very similar to as that of TAVI in SAVR. Now, before I go any further and talk a little bit about the lifetime management, this is a very pertinent slide, and I thought that I should share it with you because although average expected survival at age 60 is, depending upon gender, somewhere between 23 to 25 years. And it's about 15 to 17 years at age 70. But the patients who are having aortic valve intervention, whether they are having TAVI or SAVR, they're not really your average citizen. They do have other problems. And this is Nordic data with very good completeness, and I would encourage that surgeons read this paper as well. So you can see, depending upon your risk, your survival, even at age 65, may not be 15 years. And that has to be taken into account when we are deciding whether the patient should have surgical aortic valve replacement or TAVI. What other factors should be considered? As we discussed, if the patient is female and they want to have family, then you might want to start with the Ross procedure. If that's not the consideration, of course they can have surgical aortic valve replacement with mechanical valve. Should first press procedure always be surgical aortic valve replacement? That will depend upon what is expected survival. So, when we're talking about a lifelong management, this could be done in many different orders, and that's why it will be very difficult to show which combination will do best, because you could have, as you can see from here, numerous combinations, and you would require very long follow-up. And that actually means that as all of these procedures, a straightforward isolated aortic valve replacement surgically or TAVI, become less and less complex, the decision making is much more complex. Briefly about TAVI in aortic regurgitation, that is the last frontier, but there is now a dedicated device that is available, that's been tested in studies, and is already available in common use. That is called the Trilogy, or it is also known as Genavalve before. And you can now treat aortic valves which do not have any calcification, and the mechanism of failure is pure aortic regurgitation as long as it's not bicuspid. When we have used TAVI valve designed for aortic stenosis, the outcomes are not that great. There is higher risk of embolization or migration towards ventricle. So unless they are positive or very high surgical risk, and you do not have access to Trilogy, or they are not suitable for that, then you can put balloon expandable or self-expanding valve, but it should be avoided if possible. So my final comments would be that TAVI is here, and it's being done in all risk spectrum. So risk is no longer the consideration. The consideration is anatomical and clinical factors and their expected survival. And I think decisions are increasingly more complex and should be done as a part of hard team. And for that reason, multidisciplinary teams plays more important role than it did before. In bicuspid valve, TAVI can be done, but it's still outside the randomized control data. So I think bicuspid aortic valve, especially type 0s or heavily calcified one, are for surgeon unless there's good reason not to. Valve durability, again, the question has been answered as clearly as possible with the best data that we can generate with current scientific methods, and I think it's very clear that whether you put biprosthetic surgical aortic valve or THV, they last up to 10 years very easily, with very low failure or reintervention rate. And coming back to the patient that I said you the scenario earlier, the lady could have technically a straightforward valve inside that small trifecta, which cannot be made bigger. She has small or shallow sinuses. There's very high risk of PPM, even though she didn't have PPM at the baseline. And our MDT discussion was that she should have surgical aortic valve replacement rather than TAVI, and that's what she did, and she did well. So I'll take any question you might have, or we'll go into
thanks for a great talk. If you want my personal opinion, I think the durability to me, does not play a big role. Because if you look at the data of bioprosthetic surgical aortic valve replacements, the excess mortality and structural valve degeneration, they are both competitive risks. So patients, especially the younger patients, they die before their valves degenerate. So personally, I think the whole structural valve degeneration, there's a lot of impetus on it by the industry to promote their valves, but actually, as you're saying, the survival curve for these patients is not the same as the general population. However, I find it hard to consider TAVI in the long-term management, because taking out the TAVI valve is very, it will end up being a big root replacement procedure. So, but I think considering it as a second option afterwards is probably a very good idea.
No, I think they're fair comments. If you ask me, my view would be that if somebody can have something like Inspiris, and the root is not small, they should have surgical aortic valve replacement first. And if it gives them, as the company believes, it gives them very long survival, that's good. Nothing would need to be done again, but then they can have TAVI inside that valve if needed very safely. I think what we often ignore, anatomy. Anatomy comes in very different shape and form. If sinuses are big, coronaries are high, they can have multiple procedures without any problem. When it comes to TAVI implanters, as I said, it started from the stage where we need to get the valve in. That was the challenge, and patient home. That was the challenge. We've done that, but now the debate is between durability, which comes with the supraannular replacement of the valve, as we understand the current literature now. But the downside is that you're putting a tall frame, which would mean that if they have endocarditis, if they need something else, it's a very big operation. And as I said, the mortality that we know from the explant registry suggests that it is somewhere between 12% to 25%, which is not the same for redo TAVR, for example.
And they're the ones the surgeons agree to operate on.
These are the ones surgeons agree to operate on, because there will be many.
These are the good ones.
Yeah, these are the good ones. So that debate is there. So in TAVI field at the moment, the biggest debate is what is more important, repeatability of the procedure or the durability of the valve. And as you said, durability is a complex concept, because we know from surgical data that bioprosthesis fails sooner in younger patients.
Yeah.
But it doesn't, it's paradoxical. Why with younger patient? Is that because we're putting bioprosthesis in younger patient when they have higher risk because of the other competing factors?
It could be that, but also the fact that there have been studies looking at, so the mortality is not directly linked to the structural valve degeneration.
Yes.
So they die, so the proportion of valves that structurally deteriorate at a certain time frame after the procedure is not equal to the number of patients who actually die having the valve in place. So they're both competing. They're both competing risks.
Yeah.
So I personally, I think you alluded to this about the hemodynamics. We don't know what happens at the level of the myocytes, all these excess gradients. When you put a mechanical versus a bioprosthetic valve, especially in the smaller valve sizes, there's always excessive gradients afterwards. We don't know, very little studies show how these valves behave during exercise. So, you look at effective orifice area during rest most of the time, but during exercise, whether that extra afterload has an impact on the ventricle, it's probably that's around this.
So you raise a very important study question. We could repeat that study with TAVI valve. But coming back to the hemodynamics, actually, as you know from trifecta data, that when the trifecta valve came, the hemodynamics was very good, but this did not translate into durability. And we saw that there were failures afterwards. And that's what we're grappling with in TAVI data at the moment, is that yes, you put supraannular valve, you get better hemodynamics, but does that translate into other benefits?
I think we need a bigger notion study. I think once we have a bigger notion trial, that will answer the question.
And I think answer will come, because all of this data being collected.
Yes.
We need to press the people who hold this data to publish them, to make sure that it's published.
I enjoyed this talk very much. I learned a lot. I just have one point to make about the case presentation, the woman with the trifecta. that you said she had developed patient prosthesis mismatch, and I don't think you developed that. She didn't have PPM when the valve first went in. It was an adequate valve, but it degenerated quickly, and she ended up with an obstruction. So it's a problem of structural degeneration, not mismatch. But it also underscores that it's our job at the first operation to think ahead. This is what all lifetime management is all about, which, by the way, the congenital heart surgeons have been thinking and talking lifetime management forever. You never make an incision on a baby until you know what the plan is for the whole life. But it's absolutely essential when we put that first valve in that we know what step 2 is going to be. That it has to be the right kind of valve that can be dilated, that it has to be big enough, and if it's a root replacement, the coronaries are placed high. There's studies now showing that if we don't put the implant coronaries high enough, we may not set it up well for
lose that option.
Yeah, no, I think that's slightly my misrepresentation. She didn't have a PPM at baseline, but if we were to put TAVI in, she will develop it because we put a smaller valve in.
Yeah.
That's first of all. You're absolutely right. I didn't want to be controversial, so I didn't mention aortic root enlargement. Because it doesn't happen. We would love it to happen in smaller anatomy, but it doesn't happen.
We'll come to aortic root enlargement in a minute.
Yeah.
Slight change to the program. We've run well over time. We've just got 15 minutes left before your next break to grab some tea and coffee. So we're going to change the program to not have the MDT, but we'll carry on with this stimulating question and answer session. This is the best opportunity that you have to engage with the fantastic faculty that we have today with a wide depth and experience. Before I open up to the rest of the audience, Adnan, can you just expand on the trilogy valve, because that's something new, not available in every center. Can you just talk a little bit more about the implantation of it and how you anchor that valve in no calcification?
Yeah, so far, you heard, I mean, for me this was eye-opening when I said, well, actually there is no annulus. We just make it up. There is no true aortic annulus. Just the bottom of sinus, we made it and we size our valves for that. So when TAVI started, we were all worried that it's going to go down into the ventricle or it's going to get embolized. So we came up with the idea of oversizing it. And that oversizing coupled with calcified leaflet, that's what gives the anchoring to it. TAVI valve, it stays there without suture, it doesn't go anywhere else. And the first valve was the balloon expandable, so you have a frame that adopts that shape and it stays in that shape. And then the next valve was self-expanding. You can actually have a valve, you release it in a position and it just adopts to whatever anatomy is there. So there is no leaflet anchoring, everything is sized based on the annulus. But what if we could hold the 3 leaflets out there as well as match the annulus? And that's what this Yana valve has achieved. So you have got 3 clipping points between the frame, and the leaflet comes in between that, and it holds those leaflets from all 3 sides. And what it does in return is what surgeons have always done, that you have always aligned your surgical bioprosthesis to coronaries, so commissural alignment. You always do commissural alignment. And that's one thing we have not been able to replicate in TAVI, although there are some techniques which allow you to get some approximation, about 65 to 70% of the cases for left coronary only, and not the right coronary. But this device, because you position it, you have to position in the middle of each sinus, those anchors, you in return get perfect commissural alignment for all of the cases. So that's another positive for that. The other is that it's a shorter frame. So as you were talking about, many patients with tall frame will automatically end up with aortic root replacement if they were to come back. But this valve, if they stay under the STJ junction and don't touch the root, which often the case with aortic regurgitation, you have bigger roots, then even if they were to come back, you can just excise everything and just do as a normal aortic root surgery. So the device is implanted through the femoral artery. We need slightly bigger sheath at the moment with the current standard. So current standard is about 14 French, which is about 6 millimeter vessel, 5.5, 6 millimeter femoral vessel. This one, you need at least a 6 millimeter vessel to get in because the sheath size is a bit bigger. The device is self-expanding. So there is no balloon involved, but the difference is that you're capturing each leaflet inside these the prangs in between the frame. So your sinuses are free. The leaflets haven't folded back in them. They can't obstruct the coronaries, and it's got commissional alignment. It's been so we are the 4th center in Birmingham that we're doing this. So there are 3 other centers in UK performing this, and some in Germany. In America, it's not available yet for clinical use. It's part of studies, but this is the next paradigm shift in treatment with TAVI.
How is it different from the Yana valve, which was taken off?
It's just a modification of it's Yana valve. So this is evolution of. So this is trilogy. Is the 3rd generation of that valve.
Okay.
But the mechanism is the same. That you have another way of anchoring it, not just sizing it.
No, really, it's great to hear all this. We don't often get exposed to it as surgeons. I have 2 questions. One, what should we in 2024 be telling our patients who are going for a tissue valve? What are the chances they will be suitable for a TAVI in the future?
So
Because you could say things will change,
yeah.
but at the same time, the valves we're putting in are going to be there in the 15 years' time for that patient. So, what is a reasonable figure to quote?
So it's a great question actually. This is such a paradigm shift for us because even though we can repeat the procedure, we can't do anything about what's being placed in the first place. For example, if you go as a surgeon, you can take it out and put a new thing. If a bad thing is in there, you can take it out and put a good one. We can't do that. We can't take the bad one out to put a new good one in. So we are limited. The first device is critical, but we have never taught it like this because we weren't treating younger patients. So the answer to your question, a simple answer to your question is the CT scan. A gated cardiac CT scan, in my opinion, is essential for anyone who is having any type of aortic intervention because it gives you useful information. Like you mentioned in your case, that there are certain things in the ROS that you might encounter as you open the patient. But now the CT scan is of such high quality and widely available that will give you that information beforehand. You would know whether you'll encounter that right coronary artery going in front of your area of interest or not. So we are limited by 2 things. One is the coronary heights and the sinuses. So if sinuses are roomy, you can have 3 TAVIs without developing PPM or coronary obstruction. But you know that all these come in very different size and shape, STJ junction, height. So and that's why I think this idea of centers of valve excellence will bring people like you and others, you experienced TAVI operators in, and then you can make that decision specific for a patient. If they cannot have another procedure, say a 3rd procedure, then you say, well, maybe you should go and get more definitive procedures now. You don't have to have a repeat procedure because your repeat procedure options are not great because of the anatomy you have. But the answer would be with a CT scan. I think it's pivotal.
Got a question at the back and then in the middle.
Hi, actually this question I just want to put out the entire panel. So I personally have been part of 2 cases where we had complication post-TAVI and there was immediately we were transferred to the theatre and we explanted the TAVI and anyways carried out the procedure. But both times my observation was that the stent after it is deployed, the way it kind of injures the entire ascending because it literally it was embedded in the entire wall. So does that mean, I'm just literally asking the panel, so every time if there is a TAVI explantation, does that naturally mean that you have to put an interposition as well, apart from just doing an AVR? And overall general scenario, does that not count in any studies in terms of a reoperation risk? Because a reoperation for an AVR would be much lesser than if it is a reoperation and ascending every single time.
So the limitations of any studies we have done, this is a great point actually. Limitations of all the studies that we have seen is that endpoints are decided based on what they want to show difference in. So the randomized trial that we have so far were largely powered for short-term outcomes, not for reoperations. So even, for example, Notion is not really powered to show the difference between bias prosthetic valves, function, for example. We're just saying that there is a difference, but is it powered for that? I don't know, but yeah, I don't think it was powered for it. So, first question to answer, it depends what frame they put in and what happened at the time of the implantation of that device. So if you have very tall self-expanding device, it's so tall, in horizontal aorta, it's going to touch the side of the aorta. And if at any point, as the device were coming in, they injured the aorta, there might be dissection, so you can have problems and you would have to deal with it. That would involve whether you can repair that aorta or you have to put a graft in. If you put a short frame valve and the sinuses are wide, ST junction is high, it does not touch aorta, that is not automatic root replacement. It will be like surgical aortic valve replacement, redo surgery. So that's why it's actually very important. So, one of the debates we're having, and I have been asked to talk about it, is exactly that. What is the risk of redo TAVI? And I think that really had to be decided at the time of the original implant. Sadly, it doesn't happen, because TAVI has become such straightforward, simple procedure that it's happening in far too many centers without too much consideration to it, in my opinion. And that should not be the case. And actually, as the procedures become simpler, the decision making becomes more complex, and you can't separate that. Because we have debate at the moment that, TAVI should be done in district hospital because there are waiting times, for example. And they said, well, coronary intervention is being done in district hospital, so you could do the same thing. But, and maybe it will happen because we can't stop all transformational changes, but I think it will be a mistake, a step in the wrong direction.
My question is related to the previous talk about mechanical versus bioprosthesis, especially in younger females when they, our recommendation here in Birmingham would be to go for a mechanical valve and not have a child later on. What's your experience in the US or in Liverpool about that? Because one of the guidelines said that if the warfarin requirement is less than 5 milligrams, then they can continue with warfarin even in the first trimester up until labor. So, Professor Cameron, if you could share your experience and your recommendation regarding such female population.
I don't have a lot of experience with trying to take a pregnant woman through on warfarin. I understand there are some hematologists think this can be done, lovenoxanol. I worry too much still about the threat to mother and child. So if someone, a young healthy woman, needs an aortic valve replacement before pregnancy, I would either recommend the Ross or a bioprosthesis. They can handle a second procedure after they've finished having the children. For us to tell them that they shouldn't have children, to me, is outrageous. We present their options. We present the options to them. Let them choose. But that's what I would usually recommend.
It would take a very brave person to say that to a woman in the clinic. Like Duke says, it's their choice. Patient choice is what matters.
So just for the record in Birmingham, we don't tell.
What are you doing here? I think that question just needs to be reworded. I fully agree. We don't tell women not to have children.
Neither do we, even if they're having. Other than the age group, I treat patients are having children, but we don't have that.
We had a few females which when they needed a mechanical, well, we recommended a mechanical valve because of the age, but